I'll present my colleague and my dear friend Mostafa. Mostafa is a consultant gastroenterologist, and he works at the Tidor Barhars Institute in Egypt. He's also founder of the Ru'ya, which is a very well-known institute for training and teaching. And he's going to be presenting on management of leaks with stents. Over to you, Mostafa and Hani, I understand.
All right, so before we get to Dr. Mostafa and Dr. Hani, I'll go ahead and present the second case. We have a female, 20-year-old female. On August 25th, a sleeve gastrectomy was performed. About a month later, on September 15th, the patient complained of nausea and abdominal pain. Imaging, a CT was done on September 26th, showed perigastric abscess, yet no contrast extravasation. So here we can see the abscess. 3D reconstruction. The proposed treatment that we have is endoscopic placement of self-expandable metal stent. And here we go to Dr. Mostafa.
Second patient had a recent sleeve gastrectomy, and then the patient had some clinical symptoms. CT was done and showed this very small fistula tract just below. Okay. So I have started the examination. Just before I start, I would like to, when I started here, I have seen some pus in this area, especially in this area, and I aspirated this pus. I injected contrast. Really, I didn't, I see a track. We have seen a small abscess where I push the wire. I'm probing with a very, okay. So X-ray, please. Okay, so we don't have
screen.
You can appreciate now. If I will clean my lens, you can see a little bit of this is the fistula. Okay, could you push the guide wire very slowly, Salma? Okay, if not, I will stop here. I will ask Salma to inject contrast in this part via the catheter itself. Really a very small fistula, and this is not indicated at all for internal drainage as we have seen in the first patient. Okay, injection. It's a little bit up here. Okay. You can see if you can focus on the X-ray image. This is typically, I think it's here. I'm just probing. This is. I will aspirate a little bit. And this is another challenging idea. If you can have the endoscopic view, bigger image, and just at 9 o'clock, you can see the whitish pus. So this is a very small fistula with a very small paragastric abscess. I will inject contrast. Okay, I will inject contrast in this part. Yeah, you see, this is the problem. So a lot of contrast. You have just below the cornea at the first staple line at the first staple, you have seen this very small, I would say, protrusion. This is all what we have. And this is, I think this is, what do you think, Hani? Should we proceed, or we should just leave the patient? Again, it's here. This is the part. You can see it, yeah, very small protrusion here. And this is, I think, this corresponds with the CT image.
It looks like a small sealed perigastric abscess, but yes, there is a leakage. The thing is that if we leave her, we might be losing some valuable time by delaying any intervention now, because we know from several studies that earlier intervention, whether by stenting or whatever, gives really better results. So if we just leave her for a conservative management now and TPN, yes, it could work, but yes, it could risk that further treatment could be more difficult. I would say even in some cases when you don't identify the site of leak, then you are justified to put a stent. Maybe you could be less aggressive and you can put it for a shorter period for the sake of the patient. Maybe after 2 or 3 weeks, you can remove it and see how things will go.
I will vote for your opinion, Hani, because I will put a stent. And this patient, I don't think the stent should be left in place 6 or 8 weeks. I will leave this patient for 4 weeks maximum. I will come back, remove the stent, and make sure that everything is fine. I know that this is the very small track that may open again. So what I'm going to do, I'm the same technique like that Hania has done with the balloon. I have put a very guide wire X-ray. I'm pulling back my scope. No. Keep upstairs. Yes. I'm pulling back my scope while just leaving the guide wire in the duodenum. And then I will put the mark, yes, a little bit, few millimeter up. Yes. I'll put my mark here. Stop. I'll put my mark here at the first. This is where we have seen this small protrusion. Yes. To make it a little bit lateral. On screen on. Yes. Perfect. So this is where I will put. I should cover. This is where this very small abscess. I'm pulling back my scope.
So we always have this fight now, me and Mostafa, on which type of stent.
Okay.
So I am in favor of the Egyptian school of stents. We like these ultra large, fully covered stents. Mostafa,
I'm the son of the VR. So
Mostafa, he was influenced by the Belgian school,
which is we do the stent in stent technique. Normally we put an partially covered stent on ultraflex, where we will leave it 6 weeks, and then we will come back, put a fully covered inside to do the pressure necrosis on the hyperplasia part, and then remove both of them after 1 week. No one, I think, did in this world a head-to-head study to see which one.
Covered, huh?
Yeah, the fully covered one or the partially covered one. I'm using today, for the sake of Hani first, that I will put his stent, not my stent, just to show the friendship. Huh? So I'm using a TaeWoong stent, a fully covered TaeWoong stent. I would say the pros and cons. The pros that we have a fully covered stent that it's very easy to be removed after 4 weeks. The disadvantage is, number one, is migration. And migration is, we see a lot of migration with fully covered stent. There's many techniques. One of them is clipping. Nowadays with the new visco tool, the stent fix. Sometimes you do it with the Apollo to just take two sutures at the proximal part, or simply if the stent is migrated, you can come back after a few days and just pull it back. But one of the tips that to have the stent is not to migrate. I put gel, please. That to have the stent, a very big part of it, very long part of it in the esophagus. Yeah. Where you have this, because some of our also the people putting the stents, this is okay. This is very good. So this is a real challenge. So I have while I'm putting the stent, I just pull the guide wire. So this is a very good to show that everything is. Sometimes this is real patience. We have done this. So I will
it's good to show that life is unfair.
Yeah. Life is unfair, and sometimes also this show that. We are doing a real patient, so expect this. So I will go again.
So Mostafa was talking, of course, about all the cons of the fully covered stent, as expected, because he's biased. I'd have to say, yes, these very large stents, they are terrible for the patient. They're painful. They suffer. They vomit, and they're in pain. But I have to admit, the rate of migration of these ultra long stents is really. Is really low. In our series of over about 70 patients, we have about only 15% rate of migration. So this is different than the earlier version of fully covered stents. The other advantage, of course, is that you don't need 3 procedures to put the stent and then put another stent inside it and then a third one to remove it. So it really saves a couple of procedures for this patient. But again, it's according to preference. And another great advantage of these ultra-large stents is their width. These are stents, these are giant stents. These are like 28 millimeter in diameter. So they really reduce the chance of fluid refluxing around the stent and coming up again, which is something that we see with smaller stents, these partially covered stents like the Ultraflex and so on. But again, different schools. I sometimes use the partially covered stents. Sometimes I go ahead with the fully covered. It depends on the situation in the patient, how large his esophagus is.
Okay, so I'm putting the stent now. You see, now I'm focusing on the distal part of the stent. Okay, this is enough. I will go with the X-ray to the proximal part. Come up.
No, Mark.
Okay, you can see this is the proximal part of the stent, and a little bit like this. So this means I will say 2/3 of the stent is above my mark. So I will start opening the stent. Okay, could you focus any on the
lower part?
Yes, first of the lower part. So I will just releasing the stent is simply just you need to fix the hand just to pull the other part. Yes, I'm pulling. You can see I'm releasing the distal part of the stent like this. Now, if you can go with the X-ray a little bit up. Yes, this is the mark. I'm releasing.
It's opening.
Yes, opening. Yes, still done. So I will very, very smoothly pull back my guiding catheter with the guide wire.
So, Mostafa, now we can see that the distal end is in the duodenum.
Yes.
Do you mind that?
Okay, this is another, we will play a little bit of game. So this is another disadvantage. Putting a 15 centimeter long stent of my Ultraflex, I'm always sure that the stent is not in the duodenum. However, this long stent sometimes is in the duodenum. One of the problems of this part, I will show it to you now. So this is we have the stent here. This is the proximal end. It's at 25 centimeters from the dental arch. I will go through the stent very slowly, and then
Green.
The only problem of having stent hernia is through the pylorus that you have the distal end just facing the wall of the duodenum, and this is what we see sometimes ulcer at this part. So, this is what I'm afraid about. X-ray. Can I have some contrast here? Okay, I'm injecting contrast first in this part.
Thank you very much for this excellent demonstration. I'm being told we're ready to move to Brussels. So